I'm going to finish up the second part of chapter 44, the peripheral nerve trauma, restless leg syndrome, and going to the cranial nerves for trigeminal neuralgia and Bell's palsy. First, we'll begin with the peripheral nerve injury. Most commonly affected are the medial, ulnar, radial nerves and the peroneal, femoral, and sciatic nerves as shown in picture 44.1 in your text. Common causes are vehicular accidents, sport injuries, wounds to the peripheral nerves. Patient-specific pre-existing neurological disorders, diabetes, which affects your nerve endings, extremes of body habitus, male gender, advanced age, surgical risk are all listed here. Direct surgical trauma, stretch, comprehensive dressings or casts because those can cause nerve damage, tourniquet inflation, which during surgery, hematoma or abscess formation after surgery, perioperative inflammation, and proper patient positioning. This is just a good picture on showing you the nerve issues. I found this slide that might help with your text when it talks about the 5 degrees, where the first degree, if you see here, first degree is transient or temporary. EMG studies are normal. There's possibly some myelin damage. Will be complete recovery, can take as long as 12 weeks. When you get to second degree, there's axonal damage. It will be a much slower recovery. This is 1 inch a month and can be monitored by a physiatrist, or a physical therapist. Then you get to the third degree, which is more severe and causes degeneration. You see axon and endoneurium damage. There is denervation, shows on your EMG study with the fibrillation of the muscles. It may not reinnervate to the original. Patterns of recovery are mixed and incomplete. Into the fourth degree, which you can see includes even more. Results in a large scar at the site of the nerve injury, prevents any axons from advancing distal to the level of the nerve root. EMG studies reveal denervation, changes in the affected muscles. Patient requires surgery to restore neural continuity. And then you get to the fifth degree, which is a complete transection or cutting across of the nerve, requires surgery to restore. EMG findings are the same as those for fourth degree. And your text list is a sixth degree, but I did not see a sixth anywhere. Mixed nerve injury combined with other degrees of injury commonly occurs with some fascicles of the nerves are working normally while other fascicles may be recovering. Okay, I did not see that anywhere else. They may have a flaccid paralysis, may complain of a burning sensation below the trauma or pain that increases with touch, like a hyperesthesia, or in response to environmental stimulation. I've seen that with like air, wind blowing, causing pain at the site. In your assessment, if movement is not contraindicated, the patient's motor function is assessed by putting the limb through the normal range of motion. After complete denervation, the extent of vasomotor function is reflected in skin temperature, skin color, and edema. There is a warm phase where the extremity is warm and skin appears flushed. This is over 2 to 3 weeks, and this gradually is followed by a cold phase during which the skin appears cyanotic, mottled, or reddish blue and feels cool compared with the unaffected extremity. This can result in a brittleness of the nails, a scaling of the skin, loss of hair. If you picture just like people with nerve damage in their legs, like the diabetics, how they get that scaly skin on their lower legs. Neuro checks every couple of hours. Interventions depend on the location and the type degree of injury. If the nerve is lacerated, transection surgery may be indicated. And from everything I was looking at, they actually do surgery fairly quickly now, or in most of these. After suturing, the extremity is placed in a cast to maintain the flexed position and to avoid tension on the suture line. 10 to 14 days after nerve repair, the entire dressing is removed. A splint may be applied for another 2 weeks. Physical therapy begins at that point. If a large segment of nerve has been damaged, they may have to use a nerve graft if they cannot anastomose. Splints are usually held in place with elastic wrapping or Velcro closures. Frequent neurovascular checks, which I mentioned, assessing the skin, blanching. So neuro checks like you would with any cast. And skincare is important. Atrophy of the epidermis and underlying tissue causes the skin to become more fragile, more susceptible to injury and breakdown. Nutrition is important, avoiding anything to irritate the area. If skin is dry, lanolin or cocoa butter can be used. Physical or occupational therapy for this management. Okay, so now I'm going to go into restless leg. I just thought this was a cute picture. Again, trying to give you some stress relief when I can. Restless leg is often referred to as RLS. It is a leg paresthesia. I'm going to go to this slide. Jittery, tingling sensation, creepy, crawly, urge to move. It's more so at night or when they're sitting trying to relax. Most often middle-aged and older adults. Stress can exacerbate the condition. It's related to dysfunction in the brain circuits that use neurotransmitter of dopamine. There's usually a family history, higher incidence here, pregnancy, obesity, smoking, nerve disease. It doesn't list here. Iron deficiency, anemia. It is diabetics, kidney disease, iron deficiency, Parkinson's, peripheral neuropathy. Certain medications aggravated, such as caffeine, calcium channel blockers. If you remember, your calcium channel blockers are like your cardizem or diltiazem, lithium, neuroleptics. Neuroleptics would be like Neurontin, withdrawal from sedatives. The iron deficiency anemia, I actually worked with somebody that did a study, a doctor that did a study on this and found that the ferritin level, not just your hemoglobin, hematocrit, and RBC, but an actual ferritin level that has to be ordered separately. Although the normal is, I think, 35, that those with restless leg syndrome, it's not the iron deficiency that causes it, but it can aggravate it. So keeping their ferritin level higher at like a 60 greatly decreases the incidence of their restless leg, which was interesting because I used to do that and give them more iron, even though it wasn't a high level, but it kept their low norm at a higher, at like 65, and a significant difference in it. If anybody here has restless leg or knows someone, it is very, very difficult. It impairs their sleep. They're up and down. They're restless. So you're teaching them to avoid caffeine, alcohol, to quit smoking, lose weight, exercise, do walking, stretching, doing warm baths before bedtime. Drugs that are often used for Parkinson's, dopamine agonists such as pramipixole and ropinirole, which is Requip. I hate these generic names. Some anti-epileptic drugs, taking at bedtime because it causes drowsiness during the day. correcting iron and magnesium deficiencies. I haven't seen so much with the magnesium, but more with the iron. Some patients have success with Sinemet combination of levodopa and carbidopa, which is the drugs used for Parkinson's. It's really all you need to know on restless leg. Let me move on. The next section is diseases of the cranial nerves. I have 2 slides talking about cranial nerves. This one tells you what each nerve does. I find it a little busy, so this one you might find easier on each of them, giving you some cues, visual cues on helping you to remember which of the cranial nerves, because we're going to get into some of these nerves. That's just some tips to help you. I thought this was a cute slide put in here. I don't know if you have one you remember for those cranial nerves. This is mine on old Olympus towering tops. A Finn and German viewed some hops to go through all the cranial nerves. I'd never heard this one on which is sensory, which is motor, which is both. Some say marry money, but my brother says bad business, marry money. I think I've heard that somewhere in the past. I had not heard this one over here. Olympic opium occupies troubled triathletes after finishing Vegas gambling vacations still high. I don't know. I just know this one over here. Whatever method you need to use to remember your cranial nerves, you need to try to put them to memory in some fashion. Okay, so trigeminal neuralgia, which your trigeminal nerve, that's your cranial nerve, cranial nerve number 5. I always have to take myself through the mnemonic, I'm sorry. Cranial nerve number 5. It's called trigeminal because it has 3 branches. Place for pain depends on which branch is affected. You can see from here, the branch 1 is the forehead and eyes part of the nose, where the second branch is the cheek and the upper lip, and the mandibular, if you think of your jawbone or your mandible coming down. So it occurs more often in people older than age 50, women more than men. Causes a specific type of facial pain that is sudden and intense, comes in spasms, usually provoked by minimal stimulation. I think that's my next slide. Yes. No, the slide after that. Paroxysmal trigger areas, unilateral, no sensory deficit, restricted to the distribution of the trigeminal nerve, no obvious source of pathology. This is a good picture showing you some of the triggers. It doesn't take much. It is not genetic, but it is familial due to an inherited pattern of blood vessels. Trauma and infection of the teeth, jaw, or ear can contribute to it. Patients younger than 30 with pain more than one branch of the trigeminal nerve may be further evaluated to rule out possibility of a tumor or multiple sclerosis. It is very, very painful. Actually, I found some statistics on suicide rate with this, which was surprising. But I have seen people with it, and it is horribly intense pain. It is a chronic pain syndrome. It's excruciating, sharp, piercing, burning. Atypical pain described may include migraine-like headache. Pain can be initiated by light touch, change in facial expression such as smiling or chewing. Pain causes uncontrolled facial twitching. It can last for several weeks or months, followed by spontaneous remission. Priority focus is on pain management. Drug therapy, the first choice is carbamazepine, which I know is Tegretol, which is one of the seizure drugs. You'll find that many of the anticonvulsants are used for neuroleptic pain or neurological neuroleptic pain. Gabapentin, which is Neurontin, pregabalin, which Lyrica, which insurance won't cover till you fail on gabapentin because it's more expensive. I've not seen baclofen used that often. I was surprised to see that listed in here. Baclofen is really good for spastic muscle pain. I have seen acupuncture used, microvascular decompression, radiosurgery technique, peripheral chemical nerve blocks. I have seen those. This is the gamma knife, which I got a picture of it because to help you understand exactly what it is. It's a surgical approach to disrupt the trigeminal neuralgia. They can do a percutaneous stereotactic rhizotomy under general anesthesia, where they pass a hollow needle through the inside of the patient's cheek into the trigeminal nerve fibers, and a heating current or radio frequency goes through the needle to destroy some of the fibers. Oh, that just sounds painful. Glycerol injection may also be used as an option. The entire nerve is not destroyed. The advantages include long-term pain relief, absence of facial paralysis, and preservation of the sensation of touch. Puncturing the internal carotid artery is a possible complication. The affected site is permanently insensitive to pain. After the PSR procedure, apply an ice pack. Operative site is checked and the jaw for 3 to 4 hours. Focus on the cranial nervous system assessment, looking at all the facial nerves. And it talks about this microvascular decompression if it's a patient where the small artery compresses the trigeminal nerve. The procedure is more invasive, requiring a craniotomy. It's not common. It can lead to aseptic meningitis, cerebral spinal fluid leak, ipsilateral, which is hearing loss on the same side, facial nerve damage. Older adults and patients with other medical problems are not candidates. What else does it say? Psychosocial, the pain, because the pain. Okay. Complications can include headache, cranial nerve dysfunction, bleeding, assess for corneal reflex, extraocular muscle, facial nerve. That's where you need to document the changes and understand which nerve. You don't always necessarily need to know specifically all your cranial nerves, at least know what your assessments are to check all your cranial nerves. Know that there's a deficit in a cranial nerve. We're going to move on now into Bell's palsy, which facial paralysis, I've always heard it called Bell's palsy, which is cranial nerve number 7. It's just a good thing to show you the difference between Bell's palsy versus a stroke, where you can see the forehead is not involved with the stroke, it's just the facial droop. But with the Bell's palsy, cranial nerve 7, the forehead droops also. It is an acute paralysis of the vestibular cranial nerve 8. Yeah, I was thinking of my on Olympus, so that's the viewed number 8, which is your auditory, but the trigeminal or cranial nerve 5 can also be involved with this, also known as cranial polyneuritis when it's both nerves. It occurs in any age, more common in young adults. Acute maximum paralysis occurs over 2 to 5 days in almost all patients. The pain is behind the ear. That's what I've seen, is behind the ear. The patient cannot close his or her eye, wrinkle the forehead, smile, whistle, or grimace. Tearing may stop or become excessive. I've seen the excessive where the eye just keeps tearing. The face appears mask-like and sags. Taste is usually impaired to some degree, but the symptoms seldom persist beyond the second week of paralysis. They may have tinnitus or ringing in the ears, because that's the auditory nerve. Most patients go into remission in 3 months. The cause is believed to be the resultant inflammation triggered by formerly dormant herpes simplex, the herpes virus type 1. Infection, immunosuppression, or exposure to cold may trigger this HSV1 reactivation. They're rarely hospitalized. Medical management usually includes corticosteroids of high doses during the first week, antivirals such as acyclovir for herpes simplex type 1. That is a 3 times a day dosing rather than a 5 times a day that you do for the zoster. Mild analgesics may be necessary. Let me go to the next slide here. This is just a good picture on the etiology, the treatment, antivirals, corticosteroids, full recovery in 6 months. I've seen some people recover actually faster than that. The cornea must be protected from drying, just like with the myasthenia gravis, talking about using ointments, a cover patch over the eye, but this is one-sided, not both. The patient may be unable to chew, sip fluids through a straw, or control drooling on the affected side, creating difficulty at mealtimes. Encourage the patient to eat and drink using unaffected side of the mouth. High-calorie snacks to supplement using a soft diet. Explain how to use massage. Application of warm, moist heat. Facial exercises to manage the pain and the paralysis. They may have physical therapy if it's significant. Nerve blocks have been used, but it's not common. Surgery reserved for complete severe Bell's palsy to decompress the facial nerve. Most patients recover fully within a few weeks. That's what I've seen. Max of 6 months. Usually, chronic pain, they use gabapentin. Let me see, got another slide here on complications. Permanent damage to facial nerve is possible. Possible blindness due to corneal damage, which is why you need to teach them protecting that eye, using ointment, using drops, using patches. They might have permanent contracture of the facial muscles. And in here, Bell's palsy management, this is the acute paresis and paralysis. Paresis is decreased use and then the freezing of it in the prednisone. And that is actually the end of this chapter. I just thought this was a cute little thing I found. That is the end of chapter 44. Believe it or not, there's only one more chapter or part of a chapter to complete the neurological unit. And that's the end of this lecture.